It's my pleasure today to introduce Blair Comley, who was appointed Secretary of the Australian Government Department of Health and Aged Care in July last year. Blair has previously served as the Secretary of the Commonwealth Department of Climate Change and Energy Efficiency and the Commonwealth Department of Resources, Energy and Tourism. He has also been New South Wales' most senior public servant, serving as Secretary of the New South Wales Department of Premier and Cabinet. An economist, Blair has had extensive engagement with the Commonwealth state relations, including reform of the Federation and health funding. In 2012, Blair was awarded the Public Service Medal for outstanding public service in the development of public policy. He has also had significant private sector experience. That resume is very impressive. I think it's also helpful to understand the character of our speakers, so I asked a friend of mine who had known Blair for many years if she could provide 3 words to describe him. She said, "I couldn't do just 3 words to describe Blair's character. I've given you 3 and a couple of descriptors. The 3 are vision, curiosity, and empathy." She went on to say Blair's vocation is public service. His leadership is framed around serving the public and the public interest, and that he's a hugely capable and thoughtful leader committed to continuous learning and self-improvement. And I can add my comment that Blair practices what he preaches. Since leading his current department, he's had a constant mantra of 3 themes that his people need to understand. One of which is about communication, particularly about constructive and honest engagement with stakeholders. And we're delighted that he is doing that today in presenting our next session, which is Harmony in Health, ensuring all parts of the system work together. Welcome, Blair.
Thank you, Stephen. And I do feel that this presentation might be a change of pace compared with the others which have focused on personal connection, spirituality and the rejoice part of this. This may feel a bit more technocratic, but we'll see how we go. I am kind of relentlessly on message at times in terms of what I was wanting to talk about. And I did want to start talking about the capability review I was lucky enough to receive as a secretary. So it had been commissioned before I started. I started July last year. It was a review by the APSC, by 3 eminent reviewers, into what were the things the department needed to do better. And although this sounds a bit inward-looking, I think the prelude we've had from Steve is the indication of this is very outward-looking. Because the clear message we had from that capability review was that we needed to do 3 things better as a department. The first thing is we needed to lift up our strategic policy capability. And for me, strategic policy, at one level it's very simple, but it's hard to do. The very simple thing is really understanding where you want to get to in policy, and you want to get there because it's improving the well-being of the Australian people. You need to understand what the status quo is, and you need to understand how you map a transition path from the status quo to that end point. So it's pretty simple. That was the first theme. The second theme was we need to engage better with our stakeholders, and I want to come back to that in some detail. And the third theme was that we needed to empower our middle level of the organisation rather than everything gravitating up to too senior a level. So I just want to unpack these a little bit. On strategic policy, for me, there are three parts to this. The first part is that we need everyone in the department to have a clear framework of what they think is important. And I'm not going to say I can speak on behalf of what Stephen's going to talk about, but I think it's really interesting what Stephen will talk about, I think, is the frameworks that include ethical frameworks about what's really mattered. And it's pretty unusual in health that the framework that you should have doesn't have some dimension of what sort of health outcomes we're going to try and achieve, and if we can do it efficiently, but also the equity dimensions of who we're meeting and we're delivering them for. So it's really important to have a clear framework, and if you have a great framework, some things that look incredibly complex can become a lot more simple. My experience over the years doing public policy in many years is that defining the objectives of what you're trying to get is an incredibly important part of doing policy and affecting change. And most people skip over that bit far too quickly and start thinking about details and alternatives rather than what I'm fundamentally trying to achieve. The second part of good strategic policy is absolute rigour. And the rigour is rigour in communication, being very clear and direct. It's being rigorous about the numbers. It's being rigorous about what the right order of magnitude, what it's going to be achieve things. And it's about rigorous about what you can do in terms of law and governments. And then the third thing about strategic policy is to do that, you have to collaborate. No one does it in isolation. So both within our department, we need people to collaborate. We need people to start thinking about an idea and form a list of all the people they might think have an interest in that issue. And then once they go and talk to those people, it's often those people say, oh, you've missed 2 or 3 on this list. And then think about it engaging outside the department. So collaborate to get better outcomes. The second theme was that of engaging better with our stakeholders. Now, I do think it's really important that we always engage with stakeholders, and we do it not when we've made up our mind, but when we're trying to work out what the answer we're going to advise government is, and that we engage with people in a very honest and forthright manner. Now, one of the things that I think that public servants can sometimes improve is that a stakeholder says something to them which they don't agree with or they don't think is compelling, and they smile quietly and nod, right? None of you have ever seen it before, I know. They smile politely and nod, and it turns out you don't necessarily get the outcome that you're after. I think it's much more respectful if you're in a position where you think, I don't find that compelling from a stakeholder, to say, I don't find that compelling for the following reason. And I've done this quite a bit, and my observation is one of a couple of things happens. Sometimes the stakeholder says to you, actually, you've misinterpreted what I'm saying, or you haven't really understood that. Let me give you a different angle on that. And you find out, oh, no, actually, we were talking at cross purposes, or we hadn't really unpicked that issue. And you get to a better understanding. Sometimes you then say, yes, I know your explanation, but I still don't find that compelling, or I don't think it's going to fly, and it's not going to fly for either you don't have the relevant data, or that may be in your interest, but there's another group of stakeholders that are going to have quite different view of that. Now, what that allows the stakeholder to do is to go away and think about it and say, do I have a more compelling argument I could put? Can I find a bit of evidence that's actually going to cut through? And to me, that's a respectful conversation. Now, why do people not do that? Well, sometimes it's because the person will see that as a form of conflict that they just like to avoid. So at a very human level, do they want to have what they might perceive as an argument rather than a constructive exchange of views? The second reason is they might feel that they risk preempting what a minister might do or someone more senior might do. They are concerned that they say, I don't think that's going to fly, if it turns out later on that it in fact does fly because a more senior person or the minister is convinced. So they're cautious about not overcommitting. But I think what we need to do as a department is, with the appropriate caveats, put those ideas out there, challenge stakeholders to make sure that we have the best information we have to get to the right outcome. The second thing stakeholders said to us was there should be a strategic map, a narrative for the whole health and aged care system. And we don't think it currently exists in Australia. And we think that the only group that really institutionally can be the custodians of that is the Department of Health and Aged Care because of its permanence in the system. So we think you should have a map. Now, when I had this conversation internally within the department, there were some people who were really quite nervous about that. And they're quite nervous because the department does sit in an interesting part within a Westminster system, which is we serve the government of the day. If we have a strategic map, some of the question might be, where does the minister come into that? Right? Where does the minister come in? Where does the government of the day come in? Now, my answer to that is we should be thinking about the system with a 15, 20, 30-year time horizon. And those time horizons really matter in health. They really matter because we might be doing preventative actions that pay their dividends that far in advance. They really matter because if you think about us training a health workforce, many of the health workforce, it's a 10-year lead time or 15-year lead time before you end up with the trained medical graduate you want. I was at a Commonwealth State meeting and it turns out the average age of fellows being first admitted in Australia from a domestic pipeline is 39 now in Australia. They don't happen overnight. And so I think there's no real tension between a framework that thinks about the 15, 20-year time horizon, is mindful of the government of the day, but gives you a sense of a true north. And I was chatting to Stephen Duckett before, and some people often say, what's the one thing you'd like to do in health? And I sort of say, there's never one thing, you do in a system as big and complex as health. What you need to have in mind is a direction of travel, and you hope every individual decision is broadly in line with that direction of travel, or at best not wildly inconsistent with that direction of travel. And with that clear idea of the direction of travel, you can get there. So we went away as a department, we started thinking about this map, and I'm actually previewing some of this for the first time today, because I said in the department, we should work out what we think this map should look like, but then we should start testing it with stakeholders, because if it doesn't resonate with stakeholders, it's the wrong map. Now, by the way, I originally had a map in my mind. No one in the department likes it, which is a bit of a shame. I've persisted for a while, but I've kind of dropped it. The map in my mind started with this question: what genuinely affects the health and well-being outcomes of the Australian people? And it had in its mind that if that's the top, health and well-being, I have the social determinants of health, the things, like income levels, access to housing, etc. I have a range of genetic and other difficult to modify things. I have behaviours that feed into health, and I have then the health system itself. And depending who you talk to, the health system itself is actually a staggeringly small proportion of that overall map that contributes to people's health. Challenging from a health department perspective, but actually true. So the social determinants, the behaviours, the genetics, they are really very, very important. And then I had in mind that you'd map down from that, you would go through, okay, even in the health system bit, what are the services you have to provide to support the health system? What are the providers that have to supply that? What is the workforce you have to put together? What's the underlying technology? No one likes this map. They don't like this map. They don't think it's patient or individual-centred enough, and they don't think it goes to the outcomes we're trying to think. Some of them will concede that might be not a bad way to think about how the system is integrated across the things and how they're connected, but it's not the map that resonates. So we're playing with a strategic framework at the moment which has some outcomes and it has some enablers, etc. But 4 strategic priorities are what we're currently thinking as our work in progress. And these strategic priorities should feed into how we think about pivoting our attention, resources and effort within the health system. Because the reality of a health system, an aged care system, is there is an unlimited number of things that people would like us to do. But there is a limited number of things we can do, so you have to make choices. So the first theme of the 4 is prioritising prevention and early intervention. So right up there. And we can think about health, but I think about aged care too. Healthy ageing, all the things that mean that either you're not in residential aged care for a very long period of time, or you can be supported at home, or you age well that you don't need those services for as long as possible, because that gives you health, well-being and dignity in your age as you age. The second theme priority is addressing health inequities, health and aged care inequities. So it's not all about averages, it's not all about just the services or the people, but we do have to think about equity of access to health and what that means for well-being. The third is enhancing system integration. We have an incredibly integrated system. I want to come back to that in a second, but understanding and make sure that we have better integrated system. We have a very dispersed system, and sometimes I urge the people in our department to think not just about particularly the government side of health delivery, but the private sector as well. And if you think about the private sector, it's not just private hospitals or private aged care facilities. In a sense, a vast amount of the workforce which is publicly funded is essentially private sector workers that make themselves available in primary care, other things, and they're making a choice as to whether they participate in the health system, the health part of the economy, or some other part of the economy, and how intensely they do it. So all of those things have to be integrated. It'll never be run by a central planner, but what we're trying to do is make sure the incentives between all those systems make sense. You have a whole of system perspective. And the fourth theme, which I think is a little bit different to the other, I think the idea of pivoting to prevention, early intervention, health inequity, and system integration, pretty easy to understand where that sits when I sit from particularly a Commonwealth Health perspective. But the fourth one is actually leveraging available health technology and digital. And to me, that's partly because those health technology issues are essentially the foundation stone with which the health practitioners and workforce work with, but it's also likely to be a big disruptor through the system. And I saw in one of the interesting videos, people talking about AI. You can just see how AI is going to be a significant disruptor through the health system and change the way we can do things. So they're the four themes. I want to talk about a little bit enhancing system integration. And maybe an example of that, some of you may know that we are currently undertaking a private hospital financial health check. So a number of people have come to the government and have said the private hospital system is under pressure. And so we thought, well, before we do anything precipitously, what we want to do is to have an agreed fact-based, to the maximum extent possible, as to what is actually happening in that sector. And if you think about systems integration, private hospitals are a component that is linked to the whole system. The private hospitals provide services that people want to have in the private system. The existence of private hospitals have an implication for the demand on the public health hospital system. The private hospitals have to be funded from somewhere. So they're either funded by private health insurers, providing them payment for services for their members, or it's paid by someone who pays an out-of-pocket expense because they're uninsured for the hospital service, or state governments contract them for services when they want to do elective surgery not done in the private system. Once you have private health insurers paying funds to the private hospital, they have to raise it from somewhere, which is an implication for private health insurance premiums. Those private health insurance premiums, wherever they are, have an implication for affordability of private health insurance, and that relates right back to the uptake of private health insurance and what may happen in the public system. On top of that, private hospitals have to get their workforce from somewhere, in which case they're often competing with public hospitals. And if we really think about the care economy as a whole and nurses, you'll think about the connection between the private hospitals, the public hospitals, the aged care facilities, and in some cases, the NDIS. So it's all completely integrated. So what we're trying to do in that private hospital financial health check is ensure that we really understand what's going on. And one of my mantras to the team is, we may fundamentally care about health and wellbeing outcomes, but we have to understand the underlying, if you like, economics of the providers. Because if we have private players in the system, we can't expect them to do it purely for the love of it. They have to be financially viable. So we have to assess whether financial viability exists. So to take the health check forward, we're doing the analysis, but in line of engaging with stakeholders, we're engaging very heavily with stakeholders. So Martin Bowles is in the room and Steve Robson was in the room. We've got a little CEO reference group that has private hospitals, private insurers, the AMA, state government and our Treasury on it to try and agree a fact base. And we also engage with a reference group. So that's a work in progress, but we're getting the connection. Another example of systems integration is we do a lot of work with the states and territories in the National Health Reform Agreement. A very big sticker there is long stay older patients in hospitals that are not being able to discharge into aged care facilities, and we need to work through that. Now, one of the things that when I was in the New South Wales government shows the connectedness. We had a priority of moving a high proportion of people through emergency departments within 4 hours. It's in some senses a proxy for how the hospital is operating. One of the blockers of that is we had a lot of people in beds who were waiting guardianship orders. Now, the thing about that is, classic system integration, there's not much the hospital administrator can do about that, or the ED person, but it affects their flow through. So we worked with the Attorney General's Department to prioritise those cases in the Administrative Appeals Tribunal, which freed up thousands of beds over a year. It's classic system integration. So that stakeholders, 4 priorities and systems integration. Briefly, the third priority, which is probably less of interest to this audience, is empowering executives and devolving. We've got quite a large organisation, there's 7,000 people. Too much of it is done in a top-heavy way. We want to empower the others. And I genuinely believe devolving has a number of benefits. I think it increases quality because the people closest to the issues are dealing with the matters. It reduces risk because the idea that it reduces risk to have me or someone else clear 1,000 things a day is kind of nonsense. And thirdly, it gives better satisfaction for those staff. But the fourth thing it does is it actually enables us to do those other priorities better. If we devolve, we can do better strategic policy because people are closer to the action of making the decisions. But secondly, we can engage much better with our stakeholders, because there's a lot of stakeholders in health and aged care. We want a situation where you feel you can go to someone in the middle of the organisation, get just as good a hearing, get just as good a reaction, get feedback, and that they are empowered to do that. So I think it's good for the organisation and it's good externally. I'll make a couple of final points and then I'm happy to take any questions if there's any time, but I know we're behind time and I was very conscious of the person whose main objective for the conference was run on time, and we may not be on that metric at the moment. Just back to integration. I actually think there's kind of 3 stages in thinking through policy change. The first stage or level of maturity is people look at issues in isolation. So they're very deeply in their particular issue, whatever that might be. And we've got to move our department and other people away from that to think about the whole system. The second part is people are thinking about systems, but they can do 2 things. They can get lost in the complexity, and sometimes they get lost admiring the problem. So you have enormous, and I know at least one person laughed. I see this a lot. I see a lot of conversations in health and aged care where people can give you quite a good description of the interlinkages, and I did a little bit of that before when I was talking about linkages, private hospitals, public hospitals, etc. But then they stop at the point of that because they are admiring that problem. The third stage is actually, okay, so what are we going to do about it? I've got a reasonable map of the problems before me, and once I've allowed it is a systems problem, it becomes even harder to think through what do I crack through. But that stage of what do I practically do is really important. And from a departmental point of view, I think that means we need to be thinking about what the practical way forward is and testing it with stakeholders so that they can say, yeah, you could do that, but it's going to have this consequence that's problematic. And we also have to recognise that you will not be in a world where all stakeholders agree at all particular times, either because different perspectives of the facts, but also different underlying interests that they may have in the process. So the challenge is to go from the system thinking, which is incredibly important and vital, to practically how do you move forward. And sometimes I think about it, and I did spend a little time as a consultant, sometimes thinking about it kind of a 2 by 2. The vertical is what's the impact of the change you might have, and the horizontal is how difficult is it to do, whether that's financial costs, political costs, or just change management might be really hard. The top right-hand corner are high impact, high cost things or difficult things. The top left-hand is high impact, low cost. And my general view is if you've got something in that, you've made a mistake. You've probably misunderstood how difficult it is to change. Bottom right, high cost, low impact, just forget those. Bottom left, small cost, small impact. But the art of doing this in a systems way, practically moving things forward, is often to take top right-hand corner things and break them down into steps that are manageable, that are a bit more in the bottom left-hand corner, particularly if they build an evidence base or a pathway going forward. Final thing I was going to say, at the risk of admiring the problem, if I think of all the things that I'm looking at the moment where they all intertwine, we're looking at the NHRA negotiations with the states, public hospital funding, but also long-stay older patients and primary care and thin markets. We've got the private hospital review, which is looking at the financial viability of that part of the system. We've got a health technology assessment review, which is essentially about how quickly should we absorb technology from the rest of the world. What's the balance between access that drives outcomes and affordable costs? We've got a scope of practice review on what different practitioners in the health system should be doing, and can we leverage that to address our workforce challenge and get quality outcomes across the country. We're looking at thin markets because what happens in the cities is not the same in the regions, and how do we integrate that with workforce. Robin Cruck did a review of international medical graduates, and that's moving at pace to try and bring people in more quickly to fill the gaps while we build that domestic training pipeline, because you do have to think 10 and 15 years and think. On aged care, there's an Aged Care Act, which hopefully will be in Parliament soon, and the response to the task force that was looking at consumer contributions. And on top of that, in the background, the NDIS is having a profound impact in the broader care economy that links across the whole things. So that may sound like admiring the problem, but that to me is part of the landscape that we have to integrate to work out what the practical way forward, and we will need a lot of help from you to navigate this. So thank you. Happy to take some questions, but that's my sense of system integration.
Thanks for the offer to take some questions, and thanks for joining us. We've got Catholic Health Australia members in the room, and obviously they provide a hell of a lot of care in the hospital and the aged care setting. So how is the private hospital review going right now? Give us the latest. It's something I've not told anyone.
It's terrific. Can I just make one point about the hospital review? One thing we said to the people when we set it up is, we don't think of this as a review where we're going to write a report and give it to the minister. We think about this as improving our understanding and fact base, and then we're in a position to progressively advise the minister and engage with stakeholders. So I think it's been going really well. And one of the things that has been going really well is bringing the disparate parts together and allowing them to have a vigorous exchange of views about what the underlying issues are. And what you do discover is there are still some underlying differences in facts going forward. So, for example, if you were asking a pretty fundamental question about what's happened to viability, what's the contribution of, say, increase in costs? What's the contribution of changes in volumes of hospital activity? What's the contribution of the change in case mix? There's not a uniform answer. And so we'll keep working through that, because I always think when you're advising governments, it's very hard if there's a disputed fact base. If you get an agreed fact base, you can say, with that agreed fact base, we've got someone who weights this objective more highly and some weight that more objective more highly, and you can resolve that. But when you've got facts that disputes, it's very hard.
Which facts?
Well, I think facts like that, but there's also a question that in the private hospital space, none of this is homogeneous. So if you look at size, location, and the nature of the services, there's very large variation across the country. So it's clear that whilst there has been some decline in average returns, some hospitals are still doing pretty well, some are not doing so well. So there's huge diversity. So what we have to do is marry not just some one top-down view about the averages, because the averages don't tell you everything, it's in the granular thing. And so what came loud and clear from all the stakeholders, for example, is it's a very different, if a hospital were to shut in a regional centre, that has a very significantly different consequence than if I might have a densely serviced metropolitan area. So they're all the things we have to grapple with.
Well, obviously, private health system cannot survive, or without the private health insurers, vice versa. They coexist. But there are tensions at the moment and very real concerns about the viability and sustainability of the private health system, with many closures over recent years. What's your advice? What reassurances can you give that you can kind of bridge a bit of the divide?
Well, I think that the reassurance is that we're looking into the issue in earnest and we're engaging with all the people. I think that's the point. Now, the only thing I just put about the tensions is you do have commercial negotiations and bargaining between insurers and hospitals. There are 30-odd insurers, there are 650 hospitals. There will always be, if we have a negotiating outcome like that, there will always be tension. So I think the other thing you're observing is the world is not stable and people are adjusting to what the world looks like at the moment in terms of both changes in costs and other things in the landscape. So that's taking some time to work through.
Now, the question over here, please. Thank you, sir. If you could stand and ask a question, asking for questions, not statements. And if you could say where you're from, please.
Blair, thanks very much for your comments. I'm Michael Smith from the Australian Financial Review. We've been following the private hospital inquiry very closely. Philip has jumped the gun on my question there. I was going to ask a similar one, but maybe if I can phrase it another way. I know this is a health check rather than a set of recommendations at this stage, but realistically, is there anything the government can do this side of an election to give this industry some comfort that you can find a solution to some of the problems facing hospitals currently? The message we're getting back is people aren't very optimistic. And secondly, on the insurers, on the situation with insurers and the way they negotiate their funding, do you believe that system really needs some kind of reform? It just seems like at the moment insurers and hospitals can't get on. Thanks very much.
So, look, in terms of when government may a decision, if and when it's going to do anything, I'm not going to comment on that. I think, though, what I would say is what the financial health check is providing even more data on is what the particular circumstances of individual hospitals within the system are. So we have a better fact base. In terms of hospital insurers not getting on, I do think we just have to be clear, these are commercial negotiations that are happening between parties, which can sometimes, have friction in them. That's the norm rather than the exception. We do have to look at whether that system is the best system. But I would make the following comment. Having observed negotiations between commercial parties in many different areas of policy, government does have to be cautious getting in between those negotiations, because it's very hard from the outside to unpack, what's really going on in a particular negotiation. In particular, because most of these commercial negotiations are not about one simple variable or dimension. There's often, yes, there can be prices of service, but there's also risk-sharing arrangements. There's, constraints on how many days you pay out. There's a lot of detail in those that's very hard for an external party to come and look at. So, we are listening to all the parties in terms of how those negotiations are going. We're keeping a track on the outcomes in terms of the prices being paid. And we are listening to people who are proposing different solutions. But to me, that's exactly what I was talking about in the opening comments. That's exactly what we should be doing. And I think we will keep doing that, but we will be cautious about saying exactly what the direction of travel is, particularly in case it's overinterpreted.
You can tell us.
Well, I mean, just to make, one point, one of the things that makes things harder is to the extent that we have confidential discussions and then they move outside the room, that actually makes it much harder to have the sort of spitball conversation that genuinely helps move the argument forward. So I think the best conversations is when you can say to someone, well, we could do this, this and this, and then say, well, so I'm not saying we're going to do that, but we could do this and this, what would be your reaction to that, or what do you think the potentially adverse consequences are? If we can have that conversation, we can have a better outcome overall. If we have that conversation and then suddenly it's either interpreted as this is the direction of travel, that makes it genuinely harder to have that space to have the conversation.
What's at stake?
Oh, look, when I think about not just this, the whole health system, we have an integrated system which we need each part to play their part. We need to make sure that the system is genuinely viable on an ongoing basis so that we do actually deliver for the health and wellbeing of Australians. That's what's at stake.
Michael, do you have a follow-up? Or does anyone else have a question in the room?
One of your key metrics is around relationship, I think, stakeholder engagement. One of the things, colleague from the press wants to talk about possible government decisions, but one matrix that I think is completely within your control is to slow down the churn. Like if we're going to have a relationship with your 7,000 people, it means they've got to sit in a chair longer than 3.5 microseconds because we have to repeat ourselves. And increasingly, the corporate knowledge, if I could use that expression, rests with us, doesn't rest with you. So as the lead of that culture, is that something that's within your vision? Thanks.
Yeah, thanks for the question. I mean, look, I've observed over many years that there are lots of parts of government, I don't disagree with you, where stakeholders have similar roles or in the same organisations for 20, 30 years and people move through on a more regular basis. So I completely agree with that. But what I think, first of all, I think what I'm trying to do in the department is make it a better place to work so that people feel that they want to stay and that they are rewarded for making a contribution, which often comes with that longevity. The second thing I would say is when I talk about it in the department, I talk about when you do really good reform or really good transitions, you actually want a blend of people. You want some people who are deep knowledge experts and know the system really well, but you often want to blend them with people who might be coming through what I might call the more generalist or policy who understand change process, who understand broader policy settings. The best team is a mixture of the two. My observation is if you've got the people who are just churning through, they don't know it well enough and therefore they make mistakes. If you only have the people who've been in there forever, they can be a little bit too, back to the systems integration, I know my little bit but I don't know the other bits. That can be a risk. And I can't really imagine something that's a little bit more stretch because I'm so used to my environment. So I think we need to think about that mix and get the right blend.
Gosh, we could be here for the rest of the day after some of the things you've just said, and thank you so much, and thanks for taking questions. We really appreciate it, Blair. All the best, and we really look forward to the great work you do ahead. Thank you.
Thank you.